I'm excited to share some of the findings from our recent study on treating locally advanced esophageal and gastroesophageal junction cancers. Traditionally, the chemoradiation with the Carboplatin and Paclitaxel, along with perioperative chemotherapy per the FOLFOX trial, has been the standard neoadjuvant treatment for these cancers. However, even with this approach, there's still high rate of overall distant relapse rate after 10 years, around 40%, including solitary distant relapse and mixed relapse. This actually raised the question of whether we need more systemic therapy to address this kind of micrometastasis and subclinical disease, given that the weekly Carboplatin regimen is not at the treatment dosage. So to address this, we explored adding 3 cycles of induction FOLFOX before the usual chemoradiation and surgery per cross regimen, and we enrolled a total of 42 patients with localized esophageal or gastroesophageal junction cancer, including adenocarcinoma and squamous cell carcinoma. This is a single-center phase 2 single-arm study, and the initial data was actually presented at ASCO GI 2022, and here we present the final efficacy and toxicity data. I would say that the results were pretty promising. After a median follow-up of 4.4 years, we found that the 2-year disease-free survival rate was about 66-67%, and the median overall survival rate was over 5 years. The most patients completed the treatment as planned, and nearly 90% of those who had surgery had no residual disease at the surgical margin, achieving a 100% R0 resections. Additionally, 24.3% of patients who had surgeries had complete pathology complete response. From the long-term follow-up data show that our solitary distant relapse rate was 18.4%, which is lower than the historical comparison from the 10-year follow-up data of the cross trial, which was about 27%. It's important to note that some of our patients did receive adjuvant therapy, with 8 patients receiving 1 year of nivolumab, which might have influenced survival and relapse rates. Importantly, we didn't see any severe treatment-related side effects beyond what we've expected, and there were no treatment-related deaths during the induction chemotherapy and chemoradiation phases. So in summary, incorporating FOLFOX before the standard chemoradiation and surgery showed a good safety profile and improved some key outcomes. So this approach could be a beneficial addition to treatment plan for the patient with locally advanced esophageal and gastroesophageal junction cancers. One thing to consider is that several large-scale trials are currently evaluating neoadjuvant immunotherapy along with either perioperative chemotherapy or chemoradiation. So we'll need to keep an eye on those results as they come out. I believe the sequencing and combining these available therapy options need to be further explored and studied.